We now have Dr. Najafian and Dr. Alkalesh for pathology.
Okay, good morning and welcome to the first biopsy conference of NGR. On behalf of, let me put it, my first, here. On behalf of all the renal pathology group, I welcome you guys, and especially for the new fellows, I would like to first introduce ourselves. Many of you have already been in contact and have interacted with our group. There are four of us, and five renal pathologists, five of us, and also most importantly, our new fellows. So Dr. Alpers, Dr. Smith, Dr. Nicosia, Dr. Akilesh, and myself are attending, and we always love to see you guys. So stop by whenever you can and do rotations. That will be much better. I have to say that we have been having less fellows compared to the past years coming to us, and that always makes us sad. So come to us. We love to see you. We love to interact with you. And most importantly, as I said, our new fellow, Anand Patel, who came to us after doing his residency here, and prior to that, he did his MD PhD at UCLA. So this is Anand's information and contact that you may want to have. He's not presenting today, but he will present in the next sessions, and I'm sure that you will enjoy interacting with him. So without further ado, I pass the stage to Dr. Akilesh, who will present the first case. Ram.
Thank you, Behzad. Okay, let's see if I can do this. I think you have to stop the sharing there.
Go ahead.
Great, okay. All right, so let's, I'm gonna try this tool called Path Presenter to present the material today, and it'll allow us actually to review the slide in real time. So it's going to be similar to what we see at the microscope. So again, welcome to all the new fellows. So my name is Ram Akalesh. As Behzad mentioned, I'm one of the five renal pathology attendings here. And I also have a research lab where I'm very interested in a lot of genomic and spatial technologies, if that is of interest to you as well. So today's case, and also as Behzad was mentioning, we will start the biopsy conferences in each academic year with somewhat more straightforward or instructive cases to outline the normal features of the kidney biopsy for the new fellows, and then describe kind of classic pathologic alterations that may be occurring in a variety of diseases. And as the year progresses, we'll increase the degree of difficulty, if you will, with more complicated and complex cases. And as Behzad said, please send your biopsies to us. We're happy to review them. Come see, take a look at them with us. So this is a case that Dr. Yoharning sent to us, and I'll hand it over to her to describe the, let's see here, to describe the clinical presentation.
Thanks, Ram. So this is a patient who's a 54-year-old lady. She had a history of end-stage kidney disease, secondary to diabetic kidney disease, had a deceased donor kidney transplant in 2021. Basically, we saw her urgently in clinic recently because it was noted that one of her routine blood tests showed an elevated creatinine. Her baseline is about 1.2 to 1.5-ish. And she did labs and was noted to have a creatinine of 2.2. Her past medical history, as mentioned, she had type 2 diabetes for about 30 years, had all the complications of diabetes, including proliferative retinopathy, nephropathy, and neuropathy. She also has hypertension, hypothyroidism. She had multiple sclerosis, although she's not on treatment for that. Rheumatoid arthritis, she was treated with serulumab prior to a kidney transplant, but after that, never required any treatment. History of morbid obesity, status was a gastric sleeve surgery, and also history of depression. Next slide, please. So her transplant history was fairly straightforward, essentially up until now. She had a transplant about 2 years ago, got a fairly good kidney with a KDPI of about 37%, was a brain dead donor. Basically, she had a slightly high PRA at 63%, but her cross-match was negative. Essentially, no complications after transplant. The kidney worked immediately. The only thing that she did have was a little bit of BK viremia and viuria, for which we stopped her mycophenolate and started her on leflunomide. Her last BK in the serum was fairly low level at less than 22, and also very low levels of BK viuria at 82,000 copies. So the history was about a month, sorry, not a month later, but a month ago, prior to us seeing her, she visited her family, and during the trip developed what she called explosive diarrhea. Apparently she was very sick during that time, even though we never got called. She came back and did labs for us and was noted to have a creatinine of 2.2 milligrams per deciliter. Her creatinine was 1.37 a month ago. Given the history of this diarrhea and her being very sick, she saw her primary nephrologist, who decided to give her some IV fluids and repeat labs after that. So the repeat labs after she got the IV fluids about a week later showed a creatinine that was still a little bit elevated at about 1.93. And with that, we just thought that, maybe volume contraction is not what is going on. So we wanted to do a little bit further investigation. Next slide, please. We did an ultrasound. The ultrasound was fairly unremarkable. It just showed slightly elevated resistive indices. The renal artery velocity was slightly high, but it wasn't very significant. Did a UA which showed some trace blood, positive nitrates, leukocyte esterase. Her UPCR was about 0.4. Repeated her BK because of the history. Her serum BK was about 40 IUs per ml. Urine BK was about 3,000 IUs per ml. HLA antibody was negative. Cell-free DNA was unremarkable. Tacrolimus level was slightly low at about 2.9 nanograms per ml. So with this history and the question of why her creatinine was still elevated, we decided to do a kidney biopsy on her.
Okay. Thank you, Johan, for the clinical presentation. So at this point, a biopsy was performed, but perhaps before we launch into that, we can have a little bit of a discussion, perhaps put some differential diagnoses in the chat, so we can then have some ideas before we actually take a look at the tissue. Or feel free to shout them out too. Any ideas? What do you think might be going on in this patient, the transplant kidney? Okay, I see no takers. All right, so
we'll get the ball rolling just to get some chat.
All right.
Obviously, if lots of diarrhea makes me wonder about FK toxicity. Their FK levels higher. I also know their gastric sleeve, so I don't know how often you see hyperoxaluria with gastric sleeve as opposed to other surgeries.
Sure.
But could that be exacerbated by dehydration and from her diarrhea as well? So just a couple of possibilities.
Okay, so some thoughts in terms of the volume contraction, perhaps having some secondary effects and or the surgical history leading to hyperoxaluria. Thank you, Ashley. Abal has some comments as well. So he's favoring a T-cell mediated rejection process, and noting that the cell-free DNA is less sensitive for T-cell mediated rejection, maybe more for microvascular injury and antibody mediated rejection. instead. Dr. Blosser suggests probably acute tubular necrosis or acute tubular injury in the context of diabetic kidney disease. And the diabetic nephropathy, I'll note, I guess, Johan, was a clinical diagnosis. There was no prior biopsy in this transplant kidney. Okay, so thank you. Thank you for your comments. Let's take a look at the biopsy. So before we go into that, I just wanted to, again, orient the fellows in terms of what happens after you procure a kidney biopsy. So you've probably seen these vials if you've done the biopsy here in our system. We provide 3 vials. They have actually different fixatives in there. These are processed in 3 parallel streams, which we then interpret in the pathology laboratory. The light microscopy specimen, which is submitted in formalin, this green tube here, provides the most information. And so you generally want to submit your best sample for light microscopic evaluation in this tube. Immunofluorescence is processed in a frozen processing, and so that's submitted in a different media called Michel's, which is really important for immune complex mediated diseases such as lupus, IgA nephropathy, etc. So if that's in your consideration, you want to prioritize having a reasonable sample going into the immunofluorescence container as well. And finally, the third container contains glutaraldehyde-based buffer. And this is used for electron microscopy studies, the ultrastructural examination. This is going to be important for detecting amyloid fibrils, foot process effacement, and nephrotic diseases, the localization of deposits, abnormalities of glomerular basement membrane structure, and Alport-like syndromes as well. And so again, if ultrastructural features are going to be important, you want to think about submitting a sample for that as well. Now, there might be considerations where, if the patient there's a bleed after the first pass, you may have to prioritize. And so given your preclinical suspicion of what disease process might be going on, you may submit only 2 samples. Always submit for light, of course, but then feel free to give us a call, the attending on call, to help you triage what might have to be done with the other specimen as well. So let's take a look at the biopsy. So here we have this patient's biopsy, and we can see that we have several pieces of tissue, 1, 2, 3, 4 pieces of tissue, and this 5th piece over here. Now, this 5th piece is actually happens to not be kidney tissue. It actually looks like some ugly inflamed tumor, which sometimes happens. This we call a floater. When multiple specimens are being processed in the bath, then sometimes very friable tumors and material can float into another specimen's container. As far as I know, Johan, this patient does not have any ugly tumor growing in her transplant bed, and so we ascribe this to kind of a lab artifact here. But let's take a look at the tissue itself. So we can see these are some of the cores that were provided, and this stain is called the PAS, or periodic acid shift stain, which is kind of this pink colored stain. We can see the tubular parenchyma. We can start seeing glomeruli, these round structures over here, some venous structures, and a small artery over here as well. So as we look at a first pass, we can see the glomeruli over here. They show delicate mesangial regions and open capillary loops. And you basically see a lot of white space in the capillary loops because they're widely patent. There aren't a lot of inflammatory cells that are plugging up these capillary loops. We can see that the basement membranes are nice and thin and delicate. The mesangial regions are not expanded, and all the tubules are back to back. So right off the bat, we can probably rule out one of the preclinical suspicions here about advanced diabetic nephropathy. So in diabetic nephropathy, we generally see expansion of the mesangial regions, which can form nodular sclerotic regions called Kimmelstein-Wilson nodules. And we're not seeing that in this glomerulus over here. Furthermore, with diabetes, advanced diabetic kidney injury, we usually see a lot of microvascular and large vessel chronic injury in terms of hyalinosis to the vessels or arteriosclerosis. And here we passed another small artery over here, and it looks architecturally very intact. So this is a very normal looking small artery and a small vein. There's no intimal sclerosis, no hyalinosis. And so again, this argues against advanced diabetic kidney injury or disease in this particular biopsy sample. The other thing to note when we're thinking about a transplant setting, let's actually, before we go to that, let's take a look at another couple of glomeruli to make sure that I'm not just showing you, an unusual outlier glomerulus. And we can see that those same features hold true. The mesangial regions are delicate. There aren't increased numbers of cells. These central regions, which are highlighted by this PAS in the pink, are not really expanded to any significant degree. So we can say we can rule out diabetic kidney disease. The glomeruli look fairly normal. There doesn't look like there's really active glomerulonephritis either. There's not a lot of inflammation in the glomeruli. Well, what about the tubular parenchyma, right? So let's take a look at this piece, for example. So here, in the context of a transplant, and as was raised by Dr. Coralla and I think even Dr. Blosser, rejection is always in play as in the differential diagnosis. And generally, when we think about rejection in the kidney, we're looking for mononuclear cell inflammatory infiltrates that distend the interstitium and push the tubules apart. This might be associated with interstitial edema as well. And so I'm asking you to imagine this in your mind, but we're not seeing that here. We can see that the tubules, as outlined by their nice pink basement membrane over here, are sitting back to back, meaning they're pretty practically touching each other. There isn't a lot of inflammation or inflammatory cells in the tubulointerstitium. It is not expanded. And within the tubular profiles, if you look within this pink outline, we are not seeing dark hyperchromatic cells, which would indicate lymphocyte infiltration. Instead, we're seeing the kind of open-looking, kind of pale-looking nuclei of the tubular epithelial cells, and these look very, very normal. Another consideration raised by Dr. Jefferson was oxalate nephropathy. This is not the best stain to show that, and we won't be able to polarize in this particular representation, but we did not see crystals within these tubules. Okay, so here's one view. This is one of the stains that we perform out of 4 routine stains. This is the PAS stain, which gives us a lot of information about the mesangial composition, mesangial structures, and also gives us a good view into basement membranes, blood vessels, and the interstitium, especially for inflammation as well. So let's switch our views to a different kind of stain. So this is really our kind of most informative workhorse stain. This is the slide that we usually pick up first when we're evaluating the kidney biopsy. And this is a Jones methenamine silver stain. So the silver precipitates as a black material along areas of matrix and along basement membranes, such as Bowman's capsule here. We can see also the basement membranes of the tubules being nicely outlined in this black line over here. The tubules, again, look very nondescript, not too much going on there. There isn't any active inflammation. Again, when we look at the glomeruli, they have delicate mesangial regions and patent capillary loops that show normal architecture. There isn't any thickening or duplication of these basement membranes. No inflammatory influx into the capillary loops. Now, chronic injury in a Jones stain sometimes looks like this, where you can see some thickening of the basement membrane compared to its more intact tubular counterpart over here. And you can see some accumulation of grayish material in the interstitium, which is some interstitial fibrosis. But again, here, this is a very small proportion of the total kidney biopsy that we're looking at. So chronic injury overall is very minimal in this biopsy. So if I'm showing you all these normal structures, you might be wondering, why are we presenting this case at biopsy conference? Well, the reason for that is this particular area over here. So you can see that at low power, you can see that you can see normal glomeruli over here, nice plump pink tubules in this portion of the kidney biopsy. But this part looks different even at low power. There's kind of a fuzzier outline of the base membranes of the tubules. Maybe they're pushed apart by some bluish gray material in between. This glomerulus is kind of stuck in the middle of all these changes. And you can also see that it's fairly sharply localized in this portion of the biopsy, and where the tissue transitioned to a more normal appearance, like on this side, on the other side of this little patch. So let's take a closer look at what might be going on in this patch. So again, to orient your eyes, here's a normal glomerulus, normal tubules, and let's kind of start walking our way into this area that looks different. So right off the bat, we can see instead of the tubules kind of sitting back to back with their basement membranes almost touching each other, that in this area of the biopsy, they're actually pushed apart. And so you can see the tubular base membrane of one tubule over here. Here's its neighbor. Here's another neighbor. They're not touching each other. And what are they being pushed apart by? They're being pushed apart by inflammatory cells, which are all these cells in the interstitium. These small mononuclear cells over here, but also polymorphonuclear cells or neutrophils, which have this polylobated nucleus with 3 to 5 lobes. You can see 1, 2, 3 lobes over here, for example. 1, 2, perhaps 3, 4 lobes over here in this particular example. So there are mononuclear cells, but also a lot of neutrophils that are infiltrating into the interstitium and pushing apart the tubules. Now, it's not just in the interstitium. So if we look within the tubular epithelial layer itself, as outlined by the basement membrane, we can see that these inflammatory cells have found their way into the tubular epithelial cell layer itself. Now, if you think about this, the cells actually have to cross the basement membrane barrier and infiltrate into the tubular epithelial cell layer to present with this kind of appearance. So here we have tubulitis, but in contrast to the rejection type of tubulitis we see in transplants, here the mononuclear cell is present, but neutrophils are really prominent, which invokes a different kind of thinking in terms of the differential for us. Now, this inflammation is really pronounced in this area. In some areas, you can even see that the basement membrane appears to be discontinuous. So if you follow this black outline, it kind of disappears over here, where the inflammatory cells may have punched through and invaded into the epithelial cell layer. Okay. In other areas, we can even see larger collections of neutrophils within the tubules, which form neutrophil casts as well. As we keep going, we can see that this area of inflammation kind of sharply transitions into more normal-looking parenchyma over here as well. Okay. So the findings we have so far in terms of the tubulointerstitium is that we have this very sharply demarcated area of active inflammation with the prominent neutrophils, with the neutrophils actually invading into the tubules, and the presence of neutrophil casts as well within the tubules, such as is seen over here. Another finding, which is not present in this particular scan, but was present in another level section of the biopsy, was segmental glomerulosclerosis as well. So let's move ahead to some of these key findings. So this was one of the glomerulus, again, in the Jones stain section, which showed a small segment of sclerosis. This was a single isolated finding. Again, you can note that this glomerulus does not have changes of advanced diabetic nephropathy in terms of Kimmelstein-Wilson nodules. Just to emphasize the fact in terms of that sharply demarcated area of inflammation, we have tons of these neutrophils, which look like almost these little black ants that are crawling across the biopsy. They're invading into and destroying the tubular basement membranes. This is associated with some interstitial edema, which is this kind of lighter gray area. And you can see the tubules being pushed apart by this inflammation as well. Here's a higher power view of these neutrophils. You can see again that they have kind of a multi-lobed nucleus. And there are also some mononuclear cells that are kind of percolating around with this inflammatory infiltrate. And you can see here that it's punching through the basement membrane, which is discontinuous in this area. So that was one portion of the biopsy that we got, which was processed for light microscopy, as I described to you before. The second processing stream is immunofluorescence. And in this instance, it was negative, but I'm presenting here the portion of the report that describes that for the new fellows, just so that they understand what we do. So these materials are routinely stained for a panel of immune reactants, 3 immunoglobulins, IgG, AM, 2 complement components, C3 and C1q, fibrin and fibrinogen, kappa and lambda light chains, and albumin. And in transplant settings, we also will stain for C4D as well. And so in this case, this is an example of a negative immunofluorescence report. It sounds verbose, but we want to make sure that we're describing all the features and stains that we do, and that we are describing all the structures that are relevant in the kidney and whether there was any staining or not. You will note that we highlight some staining that is to be expected. For example, tubular casts will routinely stain for IgA and kappa and lambda light chains. That serves as an internal positive control, which tells us that our antibodies are actually working. Blood vessels will routinely stain for C3 as well. And this is kind of an expected staining pattern that tells us that our reagents are working on the patient's tissue as well. Okay. Actually, I see your question. I'll address it in a second as well. So the third type of modality that we have in our kidney biopsies is electron microscopy. Now, in transplant biopsies, we don't always perform electron microscopy, but in this case, since we saw FSGS, segmental sclerosis, which can be associated with proteinuria, we performed electron microscopy in this case. And here, just to orient everyone, we have at very high power, a black and white view of an electron micrograph. Here you can see some portions of the mesangium of this glomerulus. And you can see capillary loops that come in with their basement membrane, reflect off the mesangium at this attachment point, and go on out again here. When you look at an isolated capillary loop, it's got several key features. On one end, you can see that there is the endothelial cell on the luminal aspect. You might see blood cells sometimes over here. These are flat and fenestrated. There are small gaps between the endothelial cell cytoplasm. Sandwiched in between is the glomerular basement membrane. So we're looking at its thickness, its architecture. Again, note that this patient was suspected of having diabetic kidney disease, which is associated with thickening of basement membranes. That is not seen here. This is a fairly normal looking thickness of a basement membrane, normal architecture as well. On the outer aspect, we can see the podocytes, and you can see their foot processes, which should interdigitate. So 2 adjacent foot processes actually come from neighboring podocyte cell processes. And in this particular view, you can see that the foot processes are pretty well preserved. And so when we think about nephrotic syndromes and nephrotic diseases, FSGS, we might be looking for effacement of these foot processes, as I'll show you in a second or two. So let's look at the next, another view. Again, a very normal looking basement membrane. You can see some red blood cells in the capillary lumen, well-preserved podocyte foot processes. And again, this particular view emphasizes that these foot processes are coming, alternate foot processes are coming from a single cell. So this foot process and this foot process belong to a different cell compared to these ones over here. Okay, so again, very normal foot process architecture, basement membrane architecture over here. And that was the case for the majority of the biopsy. Very few capillary loops showed a little bit of effacement, as you can see here, a flattening of the foot processes, which was really focal overall in this biopsy. We're also not seeing any immune deposits in the mesangium or in the capillary walls either. So kind of a final diagnosis that we rendered in this is we suggested that acute pyelonephritis was the cause of the patient's elevated serum creatinine. And the reason for this is when we see neutrophils, and especially when we see aggressive inflammation with neutrophils like we saw in this biopsy, we are worried about infection within the kidney. This might be seeded from the blood side, in, say, in the context of an endocarditis, for example, or it can be an ascending infection from the lower urinary tract. So this is what we were the most worried about in this case. We did not see any other features that were specifically looked like rejection, but given this inflammation, we couldn't exclude that there was a hiding component of rejection as well in there. We saw this incidental FSGS, which had some focal podocyte foot process effacement, not a lot, not too much to do there overall, and overall very mild chronic injury to the parenchyma. So Dr. Jefferson brought up, with this diagnosis of acute pyelonephritis, how often do we actually see organisms, bacterial organisms in the tissue by stains? It's actually pretty rare to see it. And this may be because they're already being actively cleared. It could be the low bacterial load in the tissue itself that is still eliciting an intense inflammatory response, or it could be a sensitivity issue in terms of our ability to detect them as well. So I'll hand it over now to Johan for the clinical follow-up, and also Dr. Chow mentions, Johan, did this patient have any clinical signs or labs indicating pyelonephritis before the biopsy?
So maybe I'll answer this first and then answer Cassandra's question. So we did do a urine culture the day of the biopsy. We do a UA urine culture the day the patient had a biopsy, and that urine culture later came back as having greater than 100,000 10 to the power 5 colonies per ml of E. coli, which was pan-sensitive. So with the biopsy finding, we treated her with ciprofloxacin for 10 days. And because of her penicillin allergy, we did do a repeat blood test 2 weeks. So she was treated for 10 days. We did a repeat blood test 2 weeks later, and the creatinine was still a little bit elevated. So we do need to follow her up for that. To answer Cassandra's question, so we asked her before, and the only symptom she really had was the diarrhea. Like she described very explosive diarrhea. She felt very weak, very unwell, didn't really describe any urinary symptoms. And then after this biopsy finding, we went back and specifically said, was there any dysuria, any frequency, any pain in nothing, nothing whatsoever. Never really had fevers. She did on the day of the biopsy had a slightly elevated white count at 14,000, but when she was having the diarrhea, her white count was between 5 to 6, and of course the white count after that right now is when we repeated it was also about 6K. So not really any symptoms, and obviously the lab finding is that her urine culture was positive.
I was wondering if there's ever been any complications related to biopsying someone who has pyelo, especially in someone who's immunocompromised.
I mean, obviously it's not something that we do, and if I knew she had pyelo, I wouldn't have biopsied her.
But it's like, should we be screening people for with a UA with culture before biopsy if they're immunocompromised or?
So I used to do, when I was trained, that was one of the things that we did. We did a UA urine culture a week before. And then if there was any positive urine culture, we would treat before we put a needle in. And I think one of the if I remember correctly, and I haven't reviewed this in a while, asymptomatic bacteriuria, the only reason you would have to treat is if you were to instrument them. And so that is something that, you know, after this experience, I should probably keep in mind. Fortunately, she was well. She was completely well. And then obviously we started her on antibiotics immediately after.
All right. Thank you, Johan. Thank you for the discussion. I'll turn it over to Behzad for the second case.
Okay, thanks, Ram and Johan. So let's move to the second case. Let me see. So, all right. Are you seeing the right screen?
Yes, now it's in presenter.
Okay. Okay, all right. So,
Sorry,
Behzad,
it was in
switch
the
back.
correct,
Yeah,
correct presentation. Yeah, switch back. Sorry about that.
switch the
Yes.
screens. Mhm.
so you mean like this?
Yep, that's good.
Okay, perfect. Thank you. So yeah, I have two screens, so sometimes it gets confusing that which one is showing there. So thanks, Ram, for the intro about the normal and also the stains. All of those things become pretty useful when we go over this second case, as well as the third case if we have enough time. So the second case is about a 27-year-old pregnant woman who presents with anosarca. Dr. Bernadette Thomas from Seattle Nephrology graciously provided me with clinical history, and she told me that despite that she's being off clinically, she may attend the meeting quietly, but she won't be able to present. So I will be presenting the clinical part on her behalf, and I hope that I can do that correctly. So the patient, as I said, 27-year-old female, 6 weeks pregnant, in the last several weeks has been feeling somewhat off, extremely fatigued, sleeping all day, and with swelling all over her body, most notably in face and feet. Also has been describing pleuritic chest pain, but denying rashes, shortness of breath, blood in the urine. Past medical history is significant for hepatitis C, which has been treated. Also, opioid use disorder has been on Suboxone, and a history of IV drug abuse, but that goes back to 7 years ago, and currently does not have any alcohol abuse either. As I said, the patient is 6 weeks pregnant, or was 6 weeks pregnant at the time of presentation. Serum creatinine was 1.99, about 2. You can see the rest of the test here. Rapid flu, RSV, and COVID tests, they've all been negative. Notably, urinalysis showed 2+ protein, was negative for glucose, but was positive for leukocyte esterase, and also leukocyturia, which reminds of maybe the findings in the prior biopsy. Also some hematuria and positive for bacteria, and lots of epithelial cells in the urine. And urine culture came back and resulted this mixed flora. In CBC, as you can see, 8.4 leukocytes, and also hemoglobin 8.5, so some anemia. So nephrology consultation was performed, and history revealed no complications in regard to pregnancy. She's been on ibuprofen for past 2 days, about 2 taps a day. But while inpatient, creatinine peaked at 2.7 milligram per deciliter. Additional workup was performed. Renal ultrasound showed normal appearing kidneys. Protein creatinine ratio was 2.6 with negative ANA and negative ANCA. C3 was reduced and C4 was 12. CK was 41. And Hep C quantification came back negative, as well as Hep B with a BNP of 536. And in some of the notes, because I mean, in this case, I did not sign out. So Dr. Nicosia signed it out. I noted that there's a history of group A strep bacteremia. I don't know exactly the time course that this was discovered, though. So with that history, let me know what comes into your mind in terms of differential diagnosis. And I don't know if I can see the chat. Let's see. I can't see the chat, so all right, now I put it here. I can see that. Okay, infections-related glomerulonephritis, very good. Immune complex glomerulonephritis, C through GN spectrum, that is also very good. Okay, so those are two very good differentials. Anything else? Amyloid, history of IV drug abuse. That's a very common thing to see amyloid, especially in this region. History of proteinuria was relevant. Okay, so let's move ahead and see what we found in the biopsy. Let's see. Okay, so this is a lower mag of the light microscopy view, multiple pieces with 16 to 19 glomeruli per level section. Not much chronic injury. We had only one globally sclerotic glomerulus. And you can see in some areas in this low magnification that the tubules, as in the normal, as normal features that Ram described, and they're expected to be more back-to-back, they are not back-to-back. And, you know, there is some distance between them. But I don't see, these areas look somewhat black and also with some light areas. So at this magnification, it's a little bit difficult for me to judge about the chronicity. So I leave that to our next slide. So now we know that how hematoxylin using stain looks like, and it helps us to basically see some details about the nuclei and about the structure. So this is one of those glomeruli, and at this low magnification, you can see that the glomerulus is kind of full, and we have some accentuation in the lobular pattern. So it looks very different from the normal-looking glomeruli that you saw in the prior biopsy. And also surrounding that glomerulus, we have some leukocytes. Now, a closer look at this glomerulus, same stain, shows that we have influx of leukocytes. And what type of leukocytes are they? So if we magnify, we see that these cells indeed look very similar to the ones that you saw in the interstitium and the tubules of the prior case. So this is polymorphonuclear. So we have a glomerulonephritis, meaning that we have inflammation in the glomeruli. And also, when we have tons of neutrophils in the glomeruli, we call this an exudative glomerulonephritis. So whenever you hear about the term of exudative glomerulonephritis, that's what we mean: inflammation of the glomeruli with prominence of neutrophils in the leukocytes that are present in the glomerular capillaries and other structures. So this is periodic acid shift. Again, you're familiar with this. And the difference, aside from that this glomerulus is super hypercellular. There are a lot of cells. It's becoming difficult to tell where these cells even are located. But also we are seeing a lot of these magenta colored cells. What are they? These are indeed neutrophils. So PS is one of the good stains for better observation of the neutrophils. You see that there are multilobated nuclei. They look magenta by PAS, so it's helps us to observe these cells a little bit better. And you became familiar with the Jones methylamine silver. These are two glomeruli from the same biopsy that I'm showing, and as in this one, it's a little bit less involved, and this one is heavily involved. So in this one, as you can see, there is hypercellularity. We see increased number of cells in the mesangial regions, and also in the capillaries, we see tons of these cells. And we already on the magnified view, we looked at those cells and we saw that they are neutrophils. And some of the prominent nuclei that you see, and they're not hyperlobated, there are endothelial cells that are activated. And some other glomeruli, they had very prominent glomerulonephritis in terms of increased lobulation of the capillary tuft. But the tubular interstitium was not quite intact either. So some of the tubules were showing acute tubular injury, and there are different morphologic features of acute tubular injury, but a common feature is that instead of seeing the thick brush borders on surface on the apical aspect of these epithelial cells, we see basically kind of flattening. These are becoming kind of cuboidal flattened cells. So we have acute tubular injury in these tubules, and some of them, they contain cast. In these casts, they are not quite packed, so kind of like cellular, but what kind of cells are in there? So we will look at them closer. However, now let's look at the other stain that was mentioned, masson trichrome. So masson trichrome is the fourth stain that we do in assessment of the biopsies, and that comes handy when we want to judge about the chronicity, because in masson trichrome, so basically like the collagen extracellular matrix, it looks blue, and the brighter, darker blue, this is that globally sclerotic glomerulus that I showed you. And you see that how dark blue that glomerulus is. So wherever you see darker blue or brighter blue, that means that we have collagen deposition. And whenever you see that, no, the blue is becoming very pale, that means we have edema. So we're dealing with more acute conditions. So like in here, yes, the tubules are dilated, so we have acute tubular injury. In the interstitium, there are a lot of inflammatory cells. And do we have a lot of interstitial fibrosis? In most places, as you can see, we have very light blue. But in some areas, the blue color is becoming a little bit darker. So that means that, you know, some element of chronicity is also happening here. On the side, we are seeing two casts that they look very red, and we will look at them in the next couple of slides with another color. Okay. A few other tubules that they contain a lot of neutrophils, and these are becoming more packed, and they're getting the appearance of casts, so not scattered cells a little bit. Okay, so we're seeing some similarity with the prior case, but really we don't have tons of neutrophils or, you know, tubular destruction similar to what we saw in the prior case. And on PAS, this is how those casts look like. We have cellular casts, and we have some neutrophils that they look magenta on the color. And also in the interstitium, we have a lot of inflammatory cells, but this is a focal. This is not as packed as the prior biopsy, and also not present throughout the biopsy, just in some areas. We have this active inflammation. So let's look at those red casts. So I'm showing two different casts here for you. Both of these are H&E colors. And when I say cast, what we mean is that these cells, again, should be packed. It's like that they are really casting inside the tubular lumen. So in this one, you can easily recognize red blood cells. They are bright red. They look very fresh, in other words. And in this other one, however, we have a harder time. Maybe some of them, you know, we have some cells, so it's a cellular cast. But also, if you notice, it's like that we're seeing kind of like a ghost of red blood cells, and some of them, they're not as bright as you see in the other one. So basically, as red blood cells, they remain in the cast for a while. They lose their hemoglobin and becoming partially dehemoglobinized, and therefore Basically, that's one of the ways that we can recognize that really, truly, these red blood cells are part of the RBC cast, and they are not because of the trauma of the biopsy procedure. So now let's move to the immunofluorescence microscopy. So the immunofluorescence microscopy, the only thing that we had was really positivity in the glomeruli for C3. So this is a glomerular capillary tuft. And yes, there are deposits of the C3 here and there. Some of them are small, some of them are large. And if you ask me that where they are located, I would say, yes, some of them are in the mesangium. Some of them maybe are in the peripheral capillary walls, and we see these dot to dot to dot. So we have some bright spots, we have some dim spots, we have here, we have there. So that's something, I don't know how much really this reminds you of a starry sky, but that's the way that it had been called, because I mean, some of the stars are brighter than the other ones. Some look like they're farther than the other ones. So starry sky pattern, that's a keyword. So we've been seeing exudative glomerulonephritis, we've been seeing C3 deposition with a starry sky pattern. So all of these are keywords that basically help us to establish the diagnosis in this case. So now let's move to the electron microscopy, and you already saw the more normal looking structure of the glomerulus by electron microscopy. On low magnification here, again, you can recognize the capillary loops, you can see the red blood cells, you can see those neutrophils, leukocytes. Here you see the bilobe nucleus on a plane that are within the glomerular capillaries. And on higher magnification, we can see the same, we can recognize these neutrophils again. And also there are some other stuff that not sure here. It looks a little bit paler than in the actual PowerPoint it looks like. So pay attention to this region and to this region. So we see some round stuff, and we'll see a better view of those things in the next couple of slides. Again, some capillary loops, they show very significant, prominent influx of neutrophils, and you can recognize them by the multi-lobe nuclei. And when we look at the outside, we see that the podocyte food processes, they are partially preserved. In some areas, they are preserved. In some areas, they are widened. So there is some element of podocyte injury in the mesangial regions also that looks like they are becoming very edematous, a phenomenon that we call as mesangiolisis. They become loosened. Okay, so this is a higher mag of a close-by view. Again, you can see the neutrophils, but besides that, this is the glomerular basal membrane, this is the glomerular basal membrane, and this is glomerular basal membrane. A capillary lumen here, a capillary lumen here. We see intramembranous electron densities, a little bit ill-defined, so we have electron dense deposits inside the glomerular basal membrane, and kind of like in the subendothelial region. But just in the neighborhood, look at these. We have also these, what we call as immune type electron dense deposits. Where are they located? They're located right underneath these structures. What are these structures? Food processes. So they are subepithelial. So we have subendothelial deposits. We have here close to the mesangial region, we have the mesangial deposits, and also we have subepithelial deposits. These subepithelial deposits, many of them, they have kind of like this discrete round shape that we call as hump-like. So subepithelial hump-like deposit, starry sky pattern, C3 deposition, exudative glomerulonephritis. Put all of them together with that clinical history, you can establish a diagnosis of infection-related glomerulonephritis, which some of you did without even looking at the biopsy. So the final diagnosis was infection-related glomerulonephritis, but we also have an active tubular interstitial nephritis with leukocyte casts, especially neutrophilic casts, which raise suspicion for acute pyelo. Why raising suspicion for acute pyelo and not diagnostic for acute pyelo? Because of the difference that you could appreciate comparing this with the prior case that Ram showed. So in that one, we had recurring infiltration of the parenchyma, and also with neutrophils, and many of those neutrophils inside the tubules. But in this one, it was kind of, because in exudative glomerulonephritis, you know, some of these neutrophils, they go out as well, and they go, it looks like from the glomeruli, we can see neutrophils in the Bowman's space, we can see some neutrophils in the tubules. So in this one, in this case, it wasn't quite clear that what we are seeing in the tubules was really representing acute pyelo or not. So again, the highlighted features: C3 staining, starry sky pattern, subepithelial like deposit, but also we have deposits in other areas, and that's something that we can see depending on the timing and the severity of the infection. We can see subendothelial, mesangial deposits, and all other sorts of deposits as well. Okay, so I stop here, and it looks like we don't have time to go into the third biopsy, so we leave the third biopsy for the next session. Questions? Let me see if there's. Okay, so the stress of pregnancy likely triggered alternate pathway complement activation. This is a question that Abal has asked. Any concern for infection? I mean, as I mentioned in the history, there was group A strep bacteremia that was discovered, and it is the likely underlying thing in this patient. Whether there is, of course, I mean, the findings of exudative glomerulonephritis and C3 dominant glomerulonephritis can also be seen in C3 glomerulopathy. And if this patient continues to have problems and C3 deposition, despite treatment of infection, of course, that would be something that needs to be considered. Awful lot of chronic injury for something acute. Well, there wasn't a lot of chronic injury, so that's one of the things that you want to consider in this case. I showed you the mesotrichome. If you notice in that area that we had to infiltrate, in fact, we didn't have, let me see, let me go back. Okay, so in these areas that I'm showing, and there is expansion of the interstitium, and you have a mixture of a lot of inflammatory cells. So, and those inflammatory cells are acute inflammatory cells. They are not like chronic inflammation, lymphocytes, the resting lymphocytes that you see in that condition. When I zoom in, you see that, yes, there are a lot of neutrophils, there are histiocytes, there are active lymphocytes and those things. And adjacent to those, there is a lot of edema. But there is some chronic injury percolating in. However, what we are missing here, despite this guy, which is a globally sclerosed glomerulus, we're not seeing a lot of tubular atrophy to confirm that there is significant chronic injury. There is some chronic injury, but it wasn't a lot. So you're right in terms of that. We do not expect to see that much chronic injury for an acute condition, unless it has been going on for some time. Other questions? Okay.
There's more questions
Yeah.
that probably deserve more conversation about when you might biopsy someone who's pregnant, maybe more about the operational issues around that. But if anyone has any quick insights on that, go ahead. There's some with more experience.
Just a quick comment on that. So Iris actually looked at a series of patients that were biopsied here during pregnancy, about 30 patients, and published that a few years ago. So it is safe to biopsy women during pregnancy at early stages of pregnancy, but not at late stages of pregnancy. And obviously, a lot of care has to go into the biopsy process.
Thanks, Ashley. Thanks to all our presenters today, really informative talks. Thanks to, or congratulations to Jay for winning Biopsy Conference with his prediction on infection-related GN. And look forward to seeing you all next week. We're remote next week as well. Have a great weekend, everyone.
Have a nice weekend. Thank you.